Thanks for inviting me along today. It's not very often I get the chance to speak to a room full of clinicians. I also need to confess I haven't checked my BMI this morning, but I'm pretty sure it's probably above 27, I would guess. So I'm going to try and breathe in when we do the presentation. I don't know if people know, my role at Queensland Health is the Deputy Director General of Healthcare Purchasing and System Performance. I was previously the Exec Director in that area for the last 3 years. Most of you will either have heard of me because somebody's complained about funding and they haven't had enough funding within the hospital sector. But for those of you who don't, my role in Queensland Health is absolutely brilliant. I get to spend $12 billion every year. And there's not many people who can say that in Queensland at this moment. So I actually get to make some decisions about how we spend $12 billion. So we negotiate all the contracts with the hospital and health services across Queensland, the private providers, and also the NGO sector. So it's an absolutely brilliant role in terms of trying to influence healthcare and actually see some improvements for patients across Queensland. I guess what it also means is that we have to make some decisions about what we invest in across Queensland, and probably for the last 3 to 4 years, and it was interesting you commented on the rise in activity and surgical activity. We have had a significant focus around NEST, and actually reducing our elective surgery long waits, which have come down from about 6,000 to about 200 elective surgery long waits across Queensland, which is a great result. And I'm sure lots of people in the room have contributed to that. I guess the question is it right that we keep on directing all our growth funds at doing more and more activity? And should we actually start to make some decisions around investing our money to address some of the population health issues that are out there across Queensland at the moment? And obesity is quite clearly one of the biggest ones there. I'm no expert on obesity, and I'm sure there are more experts in the room, but one of the things I did look at was the Health of Queenslanders 2014 report, which the Chief Health Officer did, and I had a quick read through that last night. And just in terms of the forward, Jeanette's saying that obesity is arguably the most confronting public health issue of this century. And she goes on to say that the evidence is clear that obesity is fueling the prevalence of other chronic conditions, conditions like stroke, hypertension, heart attack, cancers and type 2 diabetes. So it's quite clearly a major issue for Queensland to try and address, and I guess our role in the department is to make some informed, clinically led decisions about how we invest our money to try and influence the obesity treatment across Queensland. So in terms of facts and figures, I should have perhaps thought twice about putting numbers up, because I'm guessing everybody will put numbers up today, and we will all have slightly different numbers, I would guess, as we're going through. But in terms of some of the facts and figures on there, you've seen some of this in the previous presentation around Queensland's got the highest rate of obesity on Australia. 1 in 3 adults are obese, 1 in 3 are overweight. And I guess the one that shocked me more, and it's probably not a surprise to people in the room, is the fourth one on there, that by the time we get to 2020, it's estimated that 55% of the population of Queensland will be obese or overweight, which actually surprised me when I actually got the data last night. So impacts on that are massive in terms of diabetes, cardiovascular disease, and just the general pressure that that's putting on the health system at this moment in time. We've all seen the graphs over the next 10 to 15 years. If we don't do something around chronic disease, obesity, smoking, those type of issues, the health system is going to probably become financially unsustainable going forward. So a real big focus about how we start to tackle chronic disease, and also obesity is a key part of that. In terms of some of the other data we've got on there, looking at costs, based on a sort of WA study from probably 2008, did some analysis and it estimated about 5.4% of all hospital expenditure was related to obesity. About 1.9 billion. Now I'm guessing all these numbers are underestimated, and if you go back to 2008, I would imagine they have risen significantly since then. Also started to talk about deaths, about 17,000 in 2010, which equates to over 3,000 deaths in Queensland, and in terms of costs, 11-12, about $500 million. Now I don't know, I'm sure you'll hear today some more current figures, but I would imagine that is much higher in 2015-16 than it would have been back in 2011-12. So a real big issue in terms of how we can try and get more sustainability in Queensland. It was interesting, I think one of the speakers today talked about data And I got the team just to try and sort of dig me out some stats around data, and obesity up until this year, and Kirsty will correct me if I get this wrong, was currently only coded if the condition directly impacts on the treatment. Okay, so there's a real lack of under-recording of obesity within the hospital data, and therefore it's hard to link obesity to some of the findings from treatment, some of the outcomes. One of the things that's changed in this financial year is the introduction of some new chronic condition codes, which are actually starting to allow clinicians and frontline staff to record obesity, and that should enable us to link a lot more clearly obesity with things like adverse events, incidence of chronic disease, complexity and readmission rates. And I think trying to get that data and understand it more is a key thing going forward. I also remember lots of discussions over the last couple of years about bariatric surgery. And I think one of the speakers today said, do we fund it in a public sector, do we not? And I think the data that we've got says that we don't fund it in public facilities. I don't think at this moment there's about 400 cases per annum that take place, and most of those are privately or self-funded patients. Okay, so not a massive incidence in terms of gastric band surgery, and certainly I guess an issue that you'll be talking through today at the event. So if you look at the situation, we've got rising costs, we've got rising incidence, we haven't got great data. We've got to try and do something about that as we go through the next probably 5 to 10 years. And one of the key roles we've got as a department is to try and work with clinicians and actually understand what are some of the things that the department can do to incentivise better outcomes and different models of care across Queensland, and how do we actually work with clinicians to get those ideas, bring those to the fore and actually start to implement those. A lot of the successes we've had from a purchasing perspective over the last 3 to 4 years have been clinically driven and clinically led by the networks and other lead clinicians across the state. So we recognise that for us to be successful, we've got to work with the clinicians across Queensland. So one of the things we're starting to explore in the department, across Kirstein's area, my areas and others, is how do we actually improve value in how we purchase our services? How do we actually get better outcomes for every dollar spent in Queensland? Okay, now there's a problem there automatically, because trying to define outcomes is going to be extremely difficult, but how do we actually start to invest the $12 billion we've got at our disposal in different ways to try and improve the value and try and improve patient outcomes across Queensland? That's, I think, the challenge we've got going forward. What we've got to do then is actually go back and evaluate the value that we're getting from the existing models of care and the existing treatments that are taking place across Queensland. That's what we have to start to try and do, and understand the value we're getting from each of those treatments. It's also going to lead us into some interesting questions about whether more treatment is necessarily a good thing. Okay, and I'm not going to delve there in a room full of clinicians, but is actually increasing the intensity of treatment for patients a good thing? When you also talk about some of the very expensive procedures that we can undertake in Queensland, do we need to do more of those? Okay, and what we're getting at there is there are a number of treatments out there, and I think the first presenter talked about bariatric surgery and things like that. When you come and look at the evidence, that is very expensive in the first year, but I would imagine if you look across the next 5 to 10 years, it might be clinically and cost effective to actually undertake those treatments. So we've got to start to look at some of those high-end treatments and see if we can generate greater value and greater outcomes from those. Just to give you a bit of a rationale as to why we focus on value, a lot of this you will all be familiar with. Okay, so this won't be new news. Most of you will be aware that Commonwealth funding arrangements are changing. So from July 2017, the Commonwealth will not link its funding to the state with the level of activity undertaken. Okay, now I'm guessing that's not news to you all in the room. Most of you will be aware of that. So for this year and for next year, the more activity that clinicians do across Queensland, the Commonwealth funds 45% of the cost of those treatments. And that's another reason that we're seeing the increase in activity across Queensland. We pass that revenue directly onto your hospital. So the more activity you do, the more a hospital gets paid at this moment in time. And that's actually uncapped. I've never known a health system that operates on an uncapped revenue model like that. However, that's changing. So from July 2017, the Commonwealth are only going to fund inflation and population growth. There will be no link to the level of activity we undertake in Queensland. So that is a massive challenge for us to try and manage the level of growth we've got in the system, because that is all going to have to be funded via the state going forward. Anything that we spend above inflation and population growth, the state will need to fund. So a real big issue. Linked to that, we know we've got to try and look to improve productivity and efficiency across Queensland over the next 3 to 4 years. And we also know we've got to introduce those patient ratios to try and improve safety and quality of care across the wards. Chronic disease I'm not going to go through. You'll spend a lot of time talking about that in the realms of obesity today, and also technology capability is actually driving a lot of the data. We had a presentation from Stephen Duckett, who a lot of you will know, on Tuesday. And when you look across the growth in healthcare costs over the last, I think, 5 to 10 years, we always think it's ageing and chronic conditions and things like that. Most of the data suggests the biggest driver is actually the frequency and intensity of treatment for the patients that have got coming in. That is by far the biggest factor that's causing a growth in healthcare costs. The other thing that we have to continue to do is improve system performance. So I think the previous speaker spoke around the number elective surgery, and we have done a brilliant job as a state. You as clinicians, the hospitals, have done a brilliant job addressing elective surgery long waits. I think probably what that masks, though, is the actual outpatient long waits that we've got in Queensland, and I think that's probably the difference between New South Wales and Victoria. We have a very different model for operating outpatients. We know now we've got over 80,000 long wait outpatients across Queensland, okay, waiting longer than clinically recommended for their outpatient appointment. Okay, now that's improving. We had over 100,000 at the start of the year, but we still have 80,000 patients who have waited longer than clinically recommended. So that will be a big focus for how we purchase services over the coming years. So I guess what it means is that we have to fundamentally understand the outcomes that we're getting from the $12 billion. And what we'd like to do is start to drill down into certain procedures. Now, I'm no expert on this, and I'm probably going where I shouldn't go in a room full of clinicians, but the team, I think, dug me out some stats around gastric bypass and gastric banding, and a lot of the evidence that they were digging out did show that that was a cost-effective treatment. Okay, when you look longer term, it seemed to imply it was a cost-effective treatment and also reduces mortality and diabetes complications. So I guess the questions within this context that we need to ask ourselves are, should we actually be funding more of those types of treatments? And I'm not going to say yay or nay today, but that's the question that we should be asking ourselves. We also need to say, does the current funding model support integrated chronic disease management? So we currently have a funding model at the moment that incentivizes treatment within a hospital setting, which is why we've seen massive growth in activity within the hospitals, and all of the hospitals have probably got stretched in terms of the capacity at this moment in time. So do we need to change the funding model to incentivize new models of care in the community and actually try and start to take the pressure off some of those acute hospitals? And should we start to invest more in prevention and community services rather than activity in an acute hospital? Okay, now prevention's always a tough call because you don't actually see the benefits for probably 10 to 15 years, but is it time that we actually started to use the growth money that we get in each year to try and invest in prevention, community services, rather than put more into the acute hospital sector? So we're looking to establish a program around promoting value in healthcare in the department, and to work with clinicians to try and, I guess, start to understand the value we're currently getting in the system and how we can try and improve value from the resources we've got at our disposal. And that has to be clinically led. So we have to engage frontline clinicians in that to re-examine what we're undertaking in the current healthcare system and start to ask the questions we've got there about how do we perform, what do we actually spend our money on, and can we do it better? And start to make some value-based decisions about how we invest the funding we've got in Queensland going forward. And that's probably the first time we've started to make and started to think about making those value-based investment decisions For the last 3 to 4 years, I've certainly, and I apologise for this, tended to focus on NEAT, NEST, and all those types of things to try and improve performance there. We need to start to move that conversation onto value and how we can actually improve the value in the system. So we're starting to do something similar to that, which is looking at the link between cost and benefit. Now, the team, when they put the slides together for me, actually put examples of particular procedures on the graph, and I just thought that was far too risky today, because no doubt somebody would argue with me, so I've taken those off. But the logic would be that down in the bottom right-hand corner, where you've got lower costs but higher benefits, should we start to invest more in the sort of things that would be in that quadrant, things like the preventative health, the vaccination rates and things like that? Should we invest more down in that bottom right-hand corner? Should we deprioritise investment for those things which are costing a lot more but we're getting little benefit? Now again, Stephen Duckett and the Grattan Institute published a document, I think probably last month, around ineffective care, and it identified 5 particular procedures in certain contexts which were deemed to be ineffective and hospitals shouldn't be undertaken. Now again, I'm not going to comment on those because I hear Stephen has had lots of comments from clinicians about when those particular forms of treatment are really effective. So I'm not going to comment on those, but should we start to try and look at those ineffective procedures? The ones in the green, I guess, we've got to look to try and maintain, and there's probably 2 approaches in there. One, are there ways in which we can improve our productivity and efficiency in the way that those treatments are performed? And also, given we operate within a finite budget, should we start to ensure that those patients who will get maximum benefit from those interventions are prioritised? And a lot of you maybe in the room are involved in the clinical prioritisation criteria that the department's doing now with clinicians across the state. That is a way that we can ensure that those resources are targeted at those patients who will get maximum value from those interventions. So that's really the concept. We're at the initial stages of this. We've got a whole structure that we've got in place. I'm not going to bore you with that one. But I guess the thing to flag is some of the outputs that we're seeking to do. So trying to produce some value reports. We've had a tendency in the department over the last 3 years, certainly in my area, to look at hundreds of things and come out with hundreds of bits of information and things, and I think that is wrong. What we've got to start to focus on is 2 to 3 areas per annum that we can work with expert clinical groups to actually understand the context of the intervention and start to make some informed and evidence-based decisions about what we should and shouldn't invest in going forward. So we'd look to identify 2 or 3 areas to work in. We're working with the Clinical Senate and the Clinical Network chairs to try and identify what those first 2 to 3 areas should be over this financial year. We're also going to start to do some benchmarking, and we're going to start to try and disseminate some information from the department out to the clinical community. What never ceases to amaze me is we have brilliant evidence of great quality services within Queensland. The difficulty is actually sharing that across the hospitals and across the hospital networks. So forums like today where you actually exchange those great ideas. But we want to try and, I think, promote sharing of best practice across Queensland. I think that's a big opportunity. Where do we focus our efforts on? I'm not going to go through that in any great detail, but we're really looking to identify areas which have got scale. There is evidence and knowledge that we can improve value, and we can actually realise that value going forward. And as I say, that's the work that we're undertaking with Senate and network chairs at this moment. I couldn't let an opportunity pass when I've got a room full of clinicians without asking you a couple of questions. So, and you don't need to give me the answers to these now, but what I'd really like to know out of today, either if there's a summary document or if you want to email me, and the email details are on the slides, are what can the department do to try and improve value in the management of obesity? What should we be doing to try and help support frontline clinicians improve the value in the management of obesity? And how do we incentivise new models of care and prevention? Okay, and I'm quite genuine with that. A lot of our good ideas, if not all of them, come from frontline clinicians. You know exactly how things work out there, so genuinely interested to hear at the end of today or on the email direct to me at the end of the event, what are some of the things that you'd want the department to look at and to try and invest in going forward to improve value in the obesity space? Okay, I hope that's not been too boring, because you have a wealth of really exciting speakers today talking about flab and tsunamis and a whole host of things. So I hope that's not been too boring, but contact details are on the slide. If anybody wants to know more about purchasing or has got any great ideas, please contact me. Thank you.
Thank you very much, Nick. Any questions?
Oh, good.
You've mentioned prevention several times. The automotive industry has taken prevention to very high levels with passive safety. Is there a role for the food industry to get involved?
I would think there will be going forward. There's lots of discussion around labelling and products and things like that, so I think that's probably an area